had this patient with elevator phobia, and it was interesting that the way we worked through it was that he didn't develop that. I mean, he developed that phobia because of very stressed job that he started having. So he used to not have any problem with elevators. And when we talked about his past experience with elevators, eventually we found out that he met his wife in an elevator. So it was one of the best of his experiences. And so I urged him because I didn't know what else to do. He was on the verge of losing his job. And then I said, okay, can you remember vividly all these positive emotions that you had while you met your wife first, and every time when he started going into elevator, he would do a list of things that he remembers, like very very positive emotions, even arousal, if you will. I mean, so I don't know if that was a good thing to do, or he can we use kind of a deconditioning using a
This is
positive
a,
experience?
I think that's a good question. So, in a way, the positive experience neutralized the anxiety, and it's good we use positive imagery to neutralize the anxious imagery. There was one youngster that I saw who used to become anxious about going to school. He'd feel intimidated by the other kids. So he would have images of himself being Superman. So having said that, this is very good symptomatic relief, but it's not what we would call the elegant solution, because the person is still going to be prone to have the anxiety attacks when there's more stress or some such, or the person is feeling fatigued. So the potential for having panic attacks in the elevator is still there, even though the positive imagery helped. And there are a lot of techniques that we do use for people who are panic prone. There was one patient, he used to have to go in the subway, and I would have him read the advertisements that were just across the thing. But that was just at the beginning of therapy, because it wasn't really the solution, since it relieved the symptoms, but it did not get down to what was going to produce the symptoms, which meant that he would always be vulnerable, because he couldn't go through life just reading the signs. And as a matter of fact, I used to tell him, he said, when I'd say, what do you do? He would ask me, what do you do when I've read the signs or the advertisements one way? And I say, well, then read them backwards. Read them the other way. But you still have to do what Judy said later, which is the behavioral experiment. Is you go in without the safety behaviors are okay as an immediate expedient, so the person will get some immediate relief. But then in the long range, you have to do the behavioral experiments.
And so the elegant solution is for the panic patient to test out his idea. The next time I get these physiological or mental sensations, then this catastrophe is going to happen. To really test that out by getting the symptoms actually as bad as they can possibly get. So get that chest to be really tight and the heart beating really fast. And don't try to do anything to stop it. In fact, try to get it even worse and prove to yourself once and for all that these symptoms are not dangerous. The catastrophe is not going to happen.
That's right. And one way to prepare the person is to do it in the office, is to try to reproduce the attack in the office and then do the restructuring. And then when they get into the behavioral experiment, they already have the background. So Amy, do you have any further thoughts?
We should give you the microphone. Sure.
No, I agree completely. And remember what we were saying earlier about the therapist being comfortable with this as well. So as Judy was saying that we want to bring on the symptoms or maybe even bring them on to a degree that's even worse than what they actually experience in the panic attack, I can imagine that that triggers some of your own automatic thoughts as therapist as well. And so again, you can approach this yourself as a behavioral experiment and test out your prediction that it's going to somehow be a negative experience, because we've seen over and over again with doing this in our clinical work that it ends up being exactly what is needed in order to really decrease those catastrophic misinterpretations and those beliefs that something horrible is going to happen.